Hi everyone, Felix here, Advanced Clinical Practitioner with the Ealing Clinic. Thank you for returning for part 2 of Pharmacology and TRT. If you haven't watched part 1 yet, click this card up here and have a watch and then come back to this video. At the end of part 1, we were talking about the androgen receptor and how testosterone gets converted to other hormones, namely DHT and estrogens. Now there's actually 3 types of estrogen which testosterone is converted into, and this process is modulated by something called the aromatase enzyme, and is therefore referred to as aromatization. The 3 types of estrogen are estrone, or E1, estradiol, or E2, and estriol, which is known as E3. It's worth a mention here that we refer to them as E1, 2, and 3 due to the American way of spelling estrogen, which we as British clinicians spell with a silent O in front of the E, due to our cultural doff of the cap, if you will, to the classics and the history and derivation of the English language. However, I digress. Now, there is debate as to whether it is necessary to routinely monitor E2 or estradiol. Some will argue that the reason for this being that it has a profound biological activity if left unmanaged. Now, often people will cite too high an E2 and there is potential to experience things such as high blood pressure, peripheral edema, etc. And I can see where this comes from, but I think it's usually because there may be times where a little information can lead to slight misunderstanding. Have a watch of this short on estrogens for a bit more information on that. Personally, I think this needs to be looked at on a case-by-case basis. Most of the time, I'm more concerned rather if your E2 is too low, as I've seen this lead to a flattening of mood, making one appear depressed and crushing their libido and causing erectile dysfunction issues in many patients. So, what do we need for these hormones? Well, a healthy ratio is the answer. You may have heard this referred to as the T to E ratio. And this is different for every patient and can take time to figure out for each individual, as we're all very unique. So how can we manage our conversion of testosterone to estrogen, which is commonly seen in TRT? Firstly, and I think most importantly, it's body habitus. If you're an overweight or obese male, you're much more likely to overconvert your testosterone to estrogen. And that's because not only do you synthesize that aromatase enzyme in your liver like you're supposed to, but the excess fat cells are all like little mini factories that also produce that enzyme. So with more enzyme comes more conversion. Fat is therefore referred to as a substrate for aromatase. The first thing to do is to attempt to lose body fat through diet and exercise, and if we need to, we can reach for pharmacological aids such as GLP-1 agonist drugs, but only once you've shown a willing commitment to lose body fat through diet and exercise. So, are there medications available to manage high estradiol? Well, yeah, there are. Are they needed? Well, that's a big debate, isn't it? There are 2 main ones that are called aromatase inhibitors that are commonly used in TRT, and they're anastrozole and exemestane. Seeing as I've named them, then we may as well just take a little time to talk about their mechanism of action. So anastrozole modulates the aromatase enzyme, but in a reversible manner, and mainly in peripheral and mammary tissue, but it does also have an impact on serum concentration levels. This reversible bonding to the heme ion action of anastrozole means that clinically, when used, and then one attempts to discontinue its use, which is nearly always the case, what's often is a swinging rebound whereby you get a steep rise in estradiol levels very soon after the cessation of that drug being discontinued. Exemestane, however, doesn't tend to do this. This is due to its mechanism of action, which is different to anastrozole. It's known as a suicide inhibitor. It irreversibly binds in a covalent manner rather than an ionic manner like anastrozole to the aromatase enzyme, inhibiting its action and therefore reducing serum concentration levels directly. Theoretically, if used when one tapers off exemestane, you may not see that steep rise in E2 that can be observed when using anastrozole. Now, whether you use them as a tool in your arsenal as a clinician or not is entirely down to your own personal preference. So, what does this mean in terms of getting stable on TRT? Well, it's important to remember one thing from all of this, and that's the general rule of thumb in terms of pharmacokinetics, and that is reaching Cmax, otherwise known as peak plasma concentration levels, and therefore the maintenance of a steady state or relative stability. That general rule is that it takes 5 times the half-life of a drug to reach stable serum concentration levels. This applies to both starting a medication or whenever a dosage is changed. So let's look at testosterone cypionate as an example. The half-life of testosterone cypionate is between 9 to 10 days, depending on which sources you look at. So this means that when your prescribing clinician starts you on therapy or changes your dosage, you need to wait at least 45 to 50 days to fully appreciate how that change will manifest in terms of a clinical effect, so what we see or feel. So don't be panicking when your clinician alters your dose or you commence TRT and 2 weeks later you're not experiencing the effect you think you should be. These things take time. Right, this has been a very brief dip into the complexities of the pharmacology in the context of TRT. We didn't even get into first order or zero order kinetics or compartment distribution models or absorption rate or elimination rate constants. As I mentioned at the beginning of the talk, pharmacology is complex. TRT is a process. It requires titration and patience. If you enjoyed this video, please do hit like and subscribe, and make sure you hit the bell notification so you don't miss any of our uploads. I'll see you in the next one.